We're just going to go really in deep in terms of net vitals. So the first part of net vitals, and I will say the net vitals communication tool is on the LACNet's website. So for caregivers that did not get the copy today, you can absolutely go on LACNet's at any time and download this to bring to your providers at any time. So the first part is really general information, and here we have a year of diagnosis, age, gender. And the first question is really, my neuroendocrine tumor was found, 1, incidentally, 2, due to obstruction, 3, net symptoms and carcinoid syndrome, and 4, other. So this is really trying to provide a background because we know that for many patients, they might have a delayed diagnosis in their neuroendocrine tumors. And the sense that we want to get is, what happened when you were diagnosed? This can provide initial clues because if it was due to obstruction, maybe the surgeon only did a surgery to relieve the obstruction, but not necessarily do a completion surgery, and you might have to seek out additional expertise to finalize that surgical procedure. If it was due to symptoms or carcinoid syndrome, oftentimes these are hormonal, and it's really good to understand that your tumor might potentially produce excess hormones, and that should be managed somewhat differently compared to neuroendocrine tumors that are non-functional. The next part is really kind of the diagnosis. So question number 2 is, I am a neuroendocrine tumor patient and my primary tumor origin is, and it gives you a following in terms of where the specific origin of the tumor lies. And number 3 is, my neuroendocrine tumor has metastasized to the following areas. Oftentimes patients might say that their primary neuroendocrine tumor is in the liver, and that would be exceedingly rare because oftentimes a primary liver neuroendocrine tumor might not be the case, and it's potentially due to a primary site that's relatively small that has traveled to the liver. So I want to throw this back to Dr. Hendifar in terms of, can you explain to the audience just a little bit why it's important to know where the primary site of the tumor is?
Yeah, I think that, like we discussed previously, the primary site is very important when you're developing a treatment plan from the surgical perspective and from the medical perspective to decide which treatments that you're going to receive. So yeah, it's very helpful and very important to know where the primary is, and if you don't know, that's also important to check the don't know or unknown box.
So as you can see, you're already starting to have that dialogue potentially with your oncologist in the office, because that's the a key information that your provider might need when they're trying to manage your neuroendocrine tumor. So the next section is also very important in terms of pathology as well as function and symptoms. So question number 4 is, my Ki-67 proliferation index is blank, and it's usually found on a pathology report, and usually a good question to know is whether or not you have your pathology report where you can potentially see this. And question number 5 goes a little bit deeper in terms of the pathology report, in terms of whether or not your neuroendocrine tumor is well differentiated, poorly differentiated, or don't know. And then there's an additional row in terms of grading, whether it's a low-grade tumor or grade 1 tumor, grade 2 or intermediate grade tumor, or grade 3 or high-grade tumor, or not know or familiar. So I'll kind of take you just briefly through this snapshot, as I think it's relatively important, and it's one of the first conversations that many net providers will have with their patients and will want to know, because again, as you saw from Dr. Hendifar's presentation before, there has been the advent of, let's say, immunotherapy that is not necessarily effective for low-grade neuroendocrine tumors, but might be effective for high-grade neuroendocrine tumors. So this is a sample of a pathology report that you might find from your institution, and if you don't have it, I always say it's very beneficial for you to request this from the institution where you had the surgery or the biopsy. So as you can see, this was a patient who underwent a distal pancreas resection, and what was noted on the pathology report was that the patient had a pancreatic neuroendocrine tumor. It was grade 2, and it has additional information in terms of whether or not the neuroendocrine tumor has already traveled to the lymph nodes, whether or not there were positive margins, meaning that there potentially was residual tumor that was left behind at the time of surgical resection, and whether or not there was invasion in terms of the microscopic blood vessels. And then continuing on, what you also see here, usually at the very end of the report, is that they have the Ki-67 proliferation index. So for this patient has a Ki-67 proliferation index of 15%, meaning that they have a grade 2 or intermediate grade neuroendocrine tumor of the pancreas. And again, this is very important because that determines how we would potentially institute treatment. I don't know if you want to add anything else to this. So always get your pathology report, because in addition to the primary location of where your neuroendocrine tumor comes from, this is really kind of the next step in terms of trying to make a decision of what the initial treatments might be for your neuroendocrine tumor. Question number 6 is a key question in terms of my neuroendocrine tumor is either functional or non-functional. So a subset of neuroendocrine tumors will produce excess hormones. So Dr. Halpern later today will be discussing with you on the role of excess serotonin hormonal secretion as well as carcinoid syndrome and management in neuroendocrine tumors. So this is very important, and I think he'll provide a lot of in-depth detail in terms of how we try to manage serotonin for those patients that have functional neuroendocrine tumors. Question number 7 is, I have symptoms in terms of various different types of symptoms that are commonly described to us in the medical profession by patients as a result of their underlying neuroendocrine tumor. Many patients might have diarrhea as a result of treatment from their prior surgeries to remove their neuroendocrine tumors in the GI tract, or they might have diarrhea from the excess hormonal production in terms of excess serotonin and carcinoid syndrome, along with additional symptoms such as flushing, as well as shortness of breath potentially. And question 8 just builds on that in terms of how long have you had these symptoms, because if you had it for a long period of time, you might have potentially excess burden of disease or additional excess hormonal production that might have longer term complications that we have to look at from the very beginning. Anything to Okay, so question number 9 is really focusing on imaging and diagnostics. So we have a lot of different modalities that we use for the diagnosis as well as follow-up surveillance for patients that have neuroendocrine tumors. These can include a triphasic high contrast CT scan, MRI, and then we also have functional modalities to look at for the expression of somatostatin receptors on the tumors for neuroendocrine tumors, such as older scan known as the octreotide scan, which is a 3-day nuclear medicine scan, or most recently the gallium-68 dotatate PET CT scan or NET spot scan. This is very important because oftentimes we have this kind of different ideas in terms of what we're looking for with each imaging. So in terms of the functional imaging, such as the octreotide scan as well as a gallium scan, it's really trying to define how much your neuroendocrine tumor expresses somatostatin receptors, which is very important because many patients are initially being treated with somatostatin analogs, and you want to express that receptor to potentially have a lot of benefit from somatostatin analogs. And then with the revolution of PRRT as an FDA-approved treatment that also targets somatostatin, it's actually vital to see whether or not your disease expresses somatostatin or not to really make you a good candidate for a targeted therapy approach. There are additional imaging modalities that are listed here in terms of PET scans, traditional FDG PET scans. These tends to be very important in terms of high-grade neuroendocrine tumors because high-grade, poorly differentiated neuroendocrine tumors might light up on an FDG PET scan, but it wouldn't necessarily light up on a gallium-68 dotatate scan. So this is a distinguishing feature that we might be able to see for high-grade neuroendocrine tumors. In addition, many patients might have gone through colonoscopies or upper endoscopies as an initial diagnosis as well for their disease. And we also put in additional scans such as MIBG for the rare subset of patients that have pheochromocytomas or paragangliomas where MIBG target therapy might be beneficial for the patients. So as you can see, before going to part 4, we're really kind of building a story now. You are able to provide your provider as well as know for yourself where your primary tumor is coming from, what grade of the tumor it is, whether or not it's well differentiated or poorly differentiated, whether or not it produces excess hormones or not, and what type of prior imaging or diagnostic tests that you have. So as you can imagine, if you provide this to your provider, then you really start to get a complete puzzle of where you are in terms of your disease course and what is the best management moving forward. So question number 10 is really focusing on blood work. So these are common blood work that you might have had when you were initially diagnosed, or these are blood work that you are receiving as you're going through the course of the disease. So we have basic blood work, including a complete blood count as well as a basic metabolic panel, which really checks, how you're doing in terms of your hemoglobin levels, platelets, white blood cell count, as well as underlying liver function and electrolytes. Then we have some NET-specific blood work that we do. So the chromogranin A is oftentimes a blood work that we will follow for patients that have advanced disease, because sometimes chromogranin A can be used as a method to describe the underlying tumor bulk of the disease. In addition, there's different ways to test the functional component of a neuroendocrine tumor through the blood, whether it's serum serotonin, and most recently serum 5-HIAA, which is a byproduct of serotonin once it is processed within the liver. And you can also test that in the urine as well with a 24-hour urine 5-HIAA. For patients that have pheochromocytoma as well as paragangliomas, we tend to do a 24-hour urine catecholamine test, which specifically tests metanephrines as well to track the disease. And for patients that have pancreas neuroendocrine tumors, sometimes we will use blood tests such as pancreastin as well as neurokinin. So these are all different modalities of tests that you might need for your specific neuroendocrine tumor that are followed. So it's good to keep track of those levels and start to track on your own to see whether or not those blood counts are, those blood levels are either increasing or decreasing, potentially showing you that possibly you might be responding to treatment or getting stabilization of your disease. We also put the hemoglobin A1C in here because this is important. We understand that a lot of patients are on somatostatin analogs, and one of the things that somatostatin analogs might potentially do to you as a side effect is that it can elevate your blood sugar. So over time, it's very important to manage your blood sugar and make sure that your blood sugar are within reasonable levels, and the hemoglobin A1C is able to track that for a longer period of time and really get a sense of whether or not you need additional control of your blood sugars while on therapies that we give for neuroendocrine tumors. Part 5 is really for our surgical colleagues. So after this presentation, you're going to be really hearing from the surgeons initially. So you always want to know, when were your surgeries? Many NET experts that do a lot of surgeries will want to know how many surgeries have you had for the specific areas, whether it's removing the primary from the small bowel or the pancreas, as well as additional surgeries in terms of liver surgeries, because sometimes there can be only a finite set of time that you might be able to have surgery. Each time you're resecting the bowel potentially gets smaller and smaller and smaller, and you might have significant diarrhea or side effects as a result of the surgery. So your surgeon will work with you to develop kind of a concrete management plan in terms of potentially how many times of surgery you might have. So this is information that a surgeon that you might be seeing might want to know so that they can plan their surgery as well as their treatments accordingly. Question 12, again, is a question that deeper in terms of surgery, in terms of resection of metastatic sites. So usually for liver surgeons, they want to make sure that depending on the date when you had the surgery, they want to know how much time has passed potentially allowing for regeneration of the liver and planning their further surgeries moving forward. Other surgeries, we put down gallbladder. Again, this is a very important information that your medical oncologist as well as your surgeons might want to know, because we know that for somatostatin analog therapy, oftentimes it can lead to cholelithiasis or gallstones. So when you're complaining of abdominal pain and you still have a gallbladder that's intact, that was not removed at the time of surgery, then this helps us to investigate that further, because your abdominal pain might not be due to the underlying neuroendocrine tumor, but it might be due to gallstones in your gallbladder, and that might need to be treated. Question 14 is focusing on liver-directed treatment. So later on in the day, you're going to hear from an interventional radiologist that talks about the modalities of all of these different types of liver-directed therapy. We know that for a majority of patients that have advanced neuroendocrine tumors tend to travel to the liver. So the site of liver is very important for us in order to maintain control of the disease as well as to prolong your survival. So these are all different modalities that are being used to specifically target the tumors within the liver. And for small tumors, it might be radiofrequency ablation. And for larger tumors, there are different types of arterial-based embolization procedures, whether it's chemoembolization, bland embolization, or radioembolization, that are being used. And you want to know how many times you've had these embolizations as well, and it's very important to your multidisciplinary team to capture that as well. Question number 15 is focusing on somatostatin analogs as well as functional control. So this just lists, what type of somatostatin analogs you've been on, whether it's short-acting or long-acting, as well as the role of Zermello for patients that have potentially excess serotonin excess and persistent carcinoid diarrhea. If you've never heard about this, I would encourage you to learn more about this from Dr. Halpern's lecture, as well as the lexicon individuals outside as well. Question number 16 has more additional treatments in terms of targeted treatments, such as Afinitor as well as sunitinib, chemotherapy that Dr. Hendifar mentioned in terms of capecitabine and temozolomide, as well as PRT. So these are all essentially treatments that we have in our armatorium, and it's worthwhile to know what are the treatment options that might work for your neuroendocrine tumor. And then to just wrap up, the final questions are kind of comorbidities in terms of do you have a history of diabetes? Again, a lot of our treatments might impact that in terms of side effects. Have you had genetic testing? We know that for a certain group of patients that have neuroendocrine tumors, this is potentially hereditary, especially for patients that have pancreas neuroendocrine tumors. So if you haven't had genetic testing, it's worthwhile to have a dialogue with your physician. And then social support, as you can see, for all the caregivers in this room, you realize how important it is to be a caregiver and to provide social support during the journey. And there are studies that are underway to investigate the role of social support for patients with neuroendocrine tumors. So these are all the resources that are available. That's also included in that vitals. You can check out these additional resources to see whether or not it works for you. So that's all I had. There is a final survey in your packet. Now that we've kind of gone through Net Vitals, it's a white form that's different from yours. So for the patients that originally got the blue folder, if you can maybe just spend 5 minutes and fill out the white survey before we go on to the next session, and pass it to your left, or find the ladies in black and we'll collect that. This will give us a sense of what you think really about Net Vitals from today. And we really thank you for everything that you do for our Los Angeles neuroendocrine tumor community. And we really hope that this tool will help all the physicians, not only in Los Angeles, but throughout the United States, provide better care for you and for you to become more knowledgeable about your disease, because we truly believe that knowledge is very important in the management of this disease from the patient perspective as well. Thank you so much.